Hello, good afternoon, everyone. This is Dr. Prerana Nesargi, Pediatric Oncologist. Well, welcome you all for the FP Live session. And today we are going to talk about advances in blood cancer and bone marrow transplant. Well, as you all know, the blood cancer does send many chills down the spine. But let me today in this FP Live session let you know about the various advances, not only in the treatment but also in the diagnosis and also follow up of the patient with respect to blood cancer, how advanced it is, and now from blood cancer being a terminal illness has zeroed down to just another disease. Okay, speaking of the statistics, for every 1 lakh population, you have 5 to 7 persons being diagnosed with one form or the other form of blood cancer. And more so, this incidence peaks in certain age groups. Blood cancer is the leading type of cancer among the pediatrics, among the children who are aged less than 15 years. Then there is a peak around the young adults as well. After this, you see a peak of blood cancer only after 60 years of age. And as everything has varieties and variants, blood cancer also is composed of different types of cancers, mainly the acute and chronic. Among the acute lymphoblastic leukemia, or commonly called as ALL, is the most common in pediatric age group less than 15 years of age. And this is followed by AML in overall incidence, which is second and more commonly among the older age population. It is acute myeloid leukemia. Then you have chronic myeloid leukemia, chronic lymphoid leukemia, which more so occurs in the later age group or the adult population. So, is the heterogeneous spectrum of blood cancers. Let me tell you one thing, that blood cancers till now have made an enormous success, right? The work began right after the World War II, and blood cancer is one of the field, particularly acute lymphoblastic leukemia is one of the cancers in which major research, I can say it is a success story of the modern medicine, is the treatment of ALL, that is acute lymphoblastic leukemia. The work started from post World War II days to till now. It has made an enormous development to an extent now that any child or any patient diagnosed with acute lymphoblastic leukemia has 95% chances of cure with appropriate diagnosis, risk stratification, and treatment. So I will make you go through the various advances the medical research has made in the field of blood cancers under the following headings, like first come, that is diagnosis, then the treatment, then the follow-up. But before diagnosis, the patient has to reach the healthcare system. So because of the availability of the skills, the doctors, nursing, and the healthcare staff, and also the easy accessibility and availability of the high-end medical services, healthcare services in the community has made it even more possible and has contributed immensely to the success stories what has been achieved in the treatment of blood cancers till date. So as I said, if you do not have a skilled person or accessibility or availability of the various modern scientific tools and facilities, it is quite a challenging task. But in today's era, thanks to the ever developing medical healthcare facilities and for the accessibility and availability of the same. So coming to the advances were made not only in treating but also in subcategorizing these blood cancers at root cause level, that is at the genetic level. So there were no diagnostics available previously. Somewhere around 20 to 25 years back, only way to diagnose was through a microscope with a simple test of CBC. When you have a suspicion clinically, look under the microscope and look for the blasts. But now it has got so evolved that even if blasts are not visible on microscopy, you can make a diagnosis based on the molecular aspects also, or the genetic aspects. So, how does this help? So, from simple CBC to peripheral smear detection of blasts, it has advanced to immunophenotypic by flow cytometry, certain specialized tests like flow cytometry, karyotyping, cytogenetics, and molecular studies. Because every blood cancer is driven by a genetic cause. I want to emphasize, by meaning genetic cause means it is not that it has been passed on from one generation to another generation. So it is only between 5 to 10% of the blood cancers are hereditary. Hereditary meaning from passed on from one generation to other generation in the form of predisposing them to increased risk of blood cancer. Let me again emphasize that it is just between 5 to 10%. Rest of the 95% of the cases are sporadic genetic mutations, somewhat similar to a random event, like how you can see one kind of a random mistake while you are coding, or a coding error crops up when you're making the codes for your app and leading to the malfunctioning of the app. So, but however, there are ways to correct it. So, there are tests available in the form of molecular genetic analysis at the molecule level to detect what has gone wrong, which has led to the unruly proliferation of these cells in the blood. So, when you know that and you're being so specific, it helps us to risk stratify the patient into something called as low risk, medium risk, and high risk. Why is this risk stratification important? It is very important because we, with the help of medical research tools, have understood that certain genetic mutations or genetic abnormalities will behave in a certain way. Certain are very nice and good and respond to the chemotherapy very well. Certain are a bit unruly and they need some specific targeted therapies to make them ruly. And the third one, the high risk, where we intensify the therapy and make sure that we achieve a higher success rate what it was before. So these diagnostic investigations like flow cytometry, molecular studies, next generation genome sequencing have made it available for us to risk stratify these blood cancer diagnosed patients into low, medium, and high. In standardized terms, standard, intermediate, and high risk groups. So accordingly, we can plan the therapy. It is not like one size fits for all. So before the invention or application of these modified and technically advanced tests, it was just one size fits all. A person who is in high risk or a person who is in low risk category were receiving the same amount of chemotherapy, because of which we were giving too much of toxicity to the low risk person and under treating the high risk person. So I hope with this example you understand that these investigations are so helpful in risk stratifying the patient, so that a low risk blood cancer person gets treated easily with chemotherapy and is spared of intense chemotherapy and the various side effects and toxicities associated with it. Following, then also we have high risk, where we can focus on certain molecular abnormalities, apply certain advanced medications in the form of targeted therapy or immunotherapy, and then give the appropriate individualized treatment so that they have a better success rate than compare and get spared from being undertreated, is what I would like to say. Then you have the intermediate group, which is carefully titrated and individualized to give the treatment so that they are spared from the excess toxicity and given the right treatment. So similarly, in the treatment, the next section comes as once the patient is diagnosed and risk stratified, you have the treatment options. Earlier, we had just weapons of mass destructions, which was heavily causing side effects in the patients, be it in the form of, having a burning sensation in the mouth, low counts, repeated blood transfusions, and all these toxicity profile, increasing the hospitalization, weakening the person as a whole, as you see in many of the movies. But now it is technically so advanced that there are so many drugs in the main armamentarium and also in the supporting group as well. Now you have got such good drugs in both the categories that the side effects can be reduced down to less than 5%, and a person can lead a normal regular life, and it will be more so of a psychological well-being more than the physical well-being in certain cases. So we also have something called as, in the main armamentarium, we have targeted therapy and immunotherapies, which are not only act at for the patient, they are individually act on specific tumor cells or the blood cancer cells. By meaning targeted therapy, these act specifically on the cells which are carrying those bad mutations or bad genetic abnormality leading to the cancer. They go to that gene level or DNA level and act and stop the cancer process. Then we have immunotherapy, where the immunotherapy helps in targeting, that is, it boosts your own patient's own immune system, and also directs and tames the immune system to attack and accelerate the attack on specifically on tumor cells, so that the normal cells are spared of the side effects what a patient would have to undergo if the patient was exposed to the conventional chemotherapy, meaning to say weapons of mass destruction. Like, you have these targeted therapies come in the form of simple tablets, like something similar to what you find in diabetes. They have to just pop in the tablet, and majority of their cancer cells are under control, or the blood cancer process is under control. And this has to be chosen based upon individualized diagnostic workup, looking at what actual genetic abnormality is there, what risk stratification they fall into, and then apply this therapy. It is, again, I'm going to emphasize, it is not one size fits for all. Okay, so these are the and these drugs, targeted therapy and immunotherapy, are very well available right from pediatric age group to the adult. Let me tell you, my friends, that the maximum amount of success with this disease has been in the pediatric age group, and this is being extrapolated to the adults. So following this treatment, or also there are certain weapons to know how the patient is doing good and how silent the blood cancer is, with respect to monitoring tools in the form of minimal residual disease. It made a history. I mean, it was a remarkable discovery as to this testing molecular level, at the molecular level, that how much of the blood cancer is still remaining, which eyes can't see, which we cannot see in the microscope. This showed that in minimal residual disease, if it is beyond a certain level, we are sure that we are going to have a relapse in a short time, or what time we can predict. But if minimal residual disease is kept at a very lower level, it is very disease specific, like meaning to say ALL will have one level of minimal residual disease, AML will have a different cutoff, so it differs from disease to disease. So if you have a very well controlled minimal residual disease, then very less likely chances that it will be taken care by the patient's own immune system, and the patient will not have a relapse. So basically what I'm trying to say is, there are tests available to monitor the patient who has already completed the therapy in the follow-up, and keep the person in follow-up and see how he is doing well, and how to anticipate in case of the disease coming back, whether it will come back or not. This minimal residual disease guides us in a very, very specific manner. And also all these are the advances recently, not recently, has been very well established in India, across the various cancer centers which are actively involved in treating blood cancer, both in pediatric and adult, and we are heading towards that. It is available, it is accessible, but mostly in the comprehensive cancer care centers, because right now it is accessible to few places. However, with the advances of in the indigenous research, and also the laboratory services and accessibility, I'm sure it is going to percolate and penetrate into the various parts and interiors of India as well. So this makes it more exciting. Now, I spoke about it so much, then how is it useful? So all these advances have made the success story of certain types of blood cancer like ALL, APML success reaching, and CML reaching up to 90 to 95%. So cancer is no more a terminal illness. Blood cancer is no more a terminal illness. It is just another disease having a very good cure rates of up to 90 to 95% in certain age groups and certain clinical scenarios and types of cancers. And so we are able to see because of these advances. We also have many advances made in the process of bone marrow transplant, also called as hematopoietic stem cell transplant. Well, somewhat similar to the kidney transplant and liver transplant, but the procedure remains bit different compared to the solid organ transplant. Here, the hematopoietic stem cells, meaning to say these are the specialized cells which have the capacity to produce the new blood in a person. Yeah. So these cells, all these long years, were thought were only in the bone marrow, which was called as inside the bones, which is called as the mother factory of blood. So it was only residing over there. But now with the advances made, so the person used to always think if a person has to donate a bone marrow stem cells for bone marrow transplant, they have to undergo a very significant process of undergoing, breaking into the bone and aspirating the marrow and all that. I can understand it is so horrifying to even imagine of it, right? Under general anesthesia on an AOT table. But let me tell you that because of the advances made in the science and technology, they also quickly found out that this whole process of donating the hematopoietic stem cells, which are sitting inside the marrow, to be mobilized to the regular blood, and making the process as simple as just that you are connected to a machine through a catheter, and then the stem cells are collected by this machine, and rest of the blood is given back to the patient, given back to the donor. So thereby the donor has to donates the hematopoietic stem cells just on an OPD setting or just a daycare setting. So it's a 4 to 6 hours job without undergoing that pain or that visuals of having the bone marrow aspirations done, drilling through the bone or getting the marrow aspirated. So this is how, so we have advanced and made this whole process as simple. And also in the bone marrow transplant, many of the newer drugs have literally spared so many patients of the toxicity and toxicity related deaths. And also thanks to the supportive care also, we have accessibility and availability now to carry on, because supportive care also plays a very important role in minimizing the side effects and also improvising on the outcomes. Because in a film, hero is important, but the supporting role is also equally important to give the essence to a movie. So similar that we have also very advances in the supportive care. And the biggest enemy or in a bone marrow transplant or hematopoietic stem cell transplant is the complication of graft versus host disease. Thanks to the advances in medical research and also the continuous work of so many scientists, that they discovered how does this whole immune system works of the donor works against the patient who has received the donor cells. And because of this, very remarkable drugs are in the market, and also procedures are in the market which help in minimizing the GVHD and have made a phenomenal change in the field of bone marrow transplant, where before you needed a fully HLA matched person to have a bone marrow transplant, but now even every recipient has a donor. So previously, about 10 years back, we used to lose out on a patient because we didn't have a donor. But now every patient has a donor, because even you can do transplant even if they are half match, just 50% match, no requirement for 100% match, because of the availability of these procedures, these drugs, and these schedules. So and a phenomenal entry into this field of bone marrow transplant, maybe in years down the lane it will be replaced by this, is especially in the treatment of blood cancers and also the various other cancers as well. But now the success story has been in blood cancer, that is the CAR T cell therapy, that is a chimeric antigen receptor T cell therapy. Basically, it is T cells are a type of your immunity cells. So these cells are taken from the patient. They are biogenetically engineered in the lab so that they target the blood cells in specific. Okay, so they're basically trained. It's just like you're picking up a person for training to join army. So they are being trained, and after well trained, this cell is even given back to the patient. It is similar to transplant, but here you do not require a donor. Patient's own cell is taken, tamed, and given back to the patient, so that these tamed and well-trained cells, immunity cells, target against the blood cancers, even at minute molecular levels. So this has been an exceptional discovery, and very happy to say that this process has been uh, replicated and also devised in India. Okay, it has been in the forefront in devising CAR T cell therapy and making it easily accessible and available for the patient. Definitely, there are some financial toxicities associated, because just now it is into the practice. But definitely down the lane, as and when we have more CAR T cell generation companies, the cost also would come down, and it will be more feasible and accessible to many of the patients who would require this kind of therapy, minimizing the toxicity and also deaths related to the side effect profile of bone marrow transplant. So, well, this was the advances I had to talk to you about in blood cancer and bone marrow transplant. I hope you understand through this talk that how science and technology and medical research has helped us to achieve over the years and stand at this point of time where cancer is just another disease, not a terminal illness, with a success rate of beyond certain infectious diseases like 90 to 95% in particular groups. It's always important to be aware of the various advances and treatment options available, so that it will help your kith and kin to get the accessibility and the strength to fight back and survive the big C word. I hope the message is conveyed through this FB Live. And always remember, be early to detect, accept, and initiate the individualized treatment. Thank you.